So thanks very much, and hi everyone. My name is Joe, and I'm a clinical researcher based in Birmingham. I'm going to be spending the next 10, 12 minutes or so talking about data sets, and in particular walking you through a project called Standing Together that we've been working on in Birmingham over the last couple of years. So hopefully I don't need to convince anyone in this audience that medical artificial intelligence has enormous potential to transform the health and wealth of citizens in our society. We've heard from many of the other speakers about some of the challenges posed by health inequalities. And depending on your viewpoint, medical artificial intelligence can either be a threat or an opportunity to help achieve more health equity. By unlocking new data-driven technologies and enabling specialist level care in remote and underserved areas, AI can be a powerful force for good. And it's a key part of the digital strategy for both the NHS and for international medical systems. But on the flip side, there's increasing evidence that AI can contribute to or cause health inequity itself. And in many cases, this has particularly affected historically marginalized and underserved groups in our society. These are really complex technologies with lots of stages involved in their development and their validation. We're all probably familiar with the adage garbage in, garbage out, but in truth, biases in healthcare AI can arise all the way through the development lifecycle, from selecting the clinical problem that we're trying to solve with these new technologies, all the way through to the way that algorithms are monitored post-deployment in the real world evaluation and use. It's not just about the data which underpins these systems, though that is a key consideration that we've been dwelling on for the last couple of years. And so let's look at the data. Well, worryingly, many analyses of healthcare data sets over the last couple of years that have been used to develop AI health technologies have highlighted that these data sets are often poorly reported. They often contain little or no demographic information, and often they don't report their limitations, although we know they must have some limitations. Put simply, in many cases, we just don't know who's represented and who's missing from such data. And this matters because when individuals are inadequately represented in healthcare data sets, digital health technologies, particularly AI health technologies, are less likely to work well for them. And we call this health data poverty, and it's a massive threat to achieving digital health equity. But in a way, none of these data set issues should be a surprise to us, because even in wealthy countries like the UK and US, there are deep social inequities driven by historical and current oppression, discrimination, and marginalization. And these inequalities drive social biases, which themselves become encoded in the data we collect and are represented then in the algorithms that we produce. So this brings me on to two key issues which I think we need to consider when we are choosing and using data sets. The first is that data sets are imperfect reflections of an imperfect reality. The process of measuring and recording people's personal characteristics generates error. And whilst we hope the size of this error is small in comparison to the measurement we're making, it can't be eliminated entirely, especially when we're dealing with complex biological social systems that are ever changing. Sometimes these errors are more frequent or are larger for certain groups of people, meaning that these people are less likely to be faithfully represented in the data sets that we collect. In other cases, people are simply absent from the data sets because of exclusion. And to make matters worse, or at least more complicated, even if our measurement was perfect and was even for every group in society, these social biases pre-existing in our society will be transmitted through to our healthcare data sets. And so if we accept that dataset bias is inevitable, at least for the time being, then I think it's really important those using the data are aware of those biases and the limitations and the implications. Transparency can't be optional. The second issue to consider is that datasets need to be appropriate for the intended use of any AI health technologies which they are used to develop. Or to put it another way, AI health technologies need to be developed and evaluated with data which is fit for their purpose. So intended use is regulatory jargon, but at its core, it describes the context in which AI and other medical devices must be used and the groups of people that it can be safely used for. Outside of the confines of the intended use, there may be insufficient evidence that an AI health technology is safe, which could put patients at risk. If metadata and documentation relating to data sets are insufficient, then we simply can't tell if data has biases or errors, or whether it matches the intended use, the purpose of the AI health technology being developed or tested. And this can narrow the intended use of the AI health technology, limiting who it can be safely used for, and meaning that certain groups are left behind as we develop and deploy these new technologies in healthcare. So this all begs the question, well, what are we going to do to help? Standing Together is an international collaboration between researchers, clinicians, technologists, medical device regulators, funders, public representatives, and many other stakeholder groups. And we've spent the last couple of years producing a set of recommendations on the documentation and use of healthcare datasets, focusing in on the composition, so that's who is represented in datasets, transparency about how decisions were made during the creation of those datasets, and the way in which datasets should be chosen and used in the development lifecycle of medical AI systems. Now, we propose that these standards are recommendations for best practice, but that individual organisations like funders or regulators might choose to mandate them at their discretion. We think they have value at every stage in the data lifecycle, but they're probably of greatest importance for datasets used in the later stages of device development or in assessment and regulatory approval. We hope that they are sufficiently principle-based, that they are relevant to any and every jurisdiction, but that they retain sufficient detail that users can see how they can easily operationalize these principles, and that they're suitably flexible to cover the diversity of populations and settings in which they might be used. We also recognise that these standards, whilst they've been developed for the context of AI and machine learning, they may also have relevance to other settings, including health data science more generally. Now, how do we create the recommendations? Well, we started off undertaking a scoping survey and systematic review of existing literature to extract about 100 candidates items. Now, these were then merged and condensed into about 30 draft items, which we passed through a two-stage electronic Delphi process, employing sequential voting and comment and refinement by our expert respondents to improve and adapt the recommendations towards their final version. After the second round of the Delphi survey, we undertook a public consultation to seek views from the wider scientific community. And then we hosted a consensus meeting in June of this year, where we invited about 30 members of key stakeholder groups to refine and ratify the final set of recommendations. We'll be publishing our final guidance later this year. Throughout the entire project lifecycle, we've had frequent touch points with our patient and public contributors. We firmly believe that this sort of work can't be done properly without hearing and amplifying the voices of the underserved groups and communities that we're trying to help. So we formed the Patient and Public Involvement and Advisory Group early on in the project. And these partners have helped us consider some of the really thorny issues that we've uncovered while delivering this work. And they've drawn on their lived experience of health inequity to help us ensure that the recommendations meet the needs of patients and service users more widely. Two of our PPIE members joined the project as co-investigators and have had substantial input to our work. Given the international scope of the recommendations, we also convened an international advisory group in the second half of the project. And this group helped us to explore some of the social concepts across different cultures and jurisdictions, so we could make sure the recommendations are fit for purpose and deliverable internationally. What's actually in the recommendations? Well, recognising that different audiences have different needs, we split the recommendations into two parts. The first part is aimed at those people who are creating datasets. It gives guidance on composition and how to achieve transparency about the content and limitations of the data. The second part is aimed at those using datasets, giving guidance about how to choose the appropriate data for their purpose, and also how to evaluate any technologies they're developing to identify groups at risk of harm and when mitigations might be needed. There's unfortunately not enough time to get into the details here, but I wanted to give all of you a quick overview of the recommendations ahead of their publication later this year. So listed here are the headings for each item in the first set of the documentation standards. In the full set of recommendations, each of these headings is accompanied by body text, which gives further clarity and instruction, and then explanatory text, which sets out the context and rationale for each item in a lot more detail. And the overall purpose, as I said, of these early parts, these documentation standards, is to improve the quality of dataset documentation, particularly encouraging transparent communication of limitations. So here's an overview of the headings in the second part of the recommendations, the data use recommendations. These focus on those people using datasets, particularly on the choice of the datasets being used and guidance on identifying groups at risk of harm where mitigation steps might be needed. Overall, across our research team, our Delphi study, our public consultation, our interview study and public advisory groups, we've engaged with over 350 stakeholders from across 58 countries. And we're really proud of this reach, but we recognise that there's still much work to do to engage those countries and communities that we haven't yet reached as we near the end of our project. So what are the next steps and how do we drive the change we want to see? Well, put bluntly, the last couple of years would have been a total waste of time if the only output is an academic paper which no one reads. From the off, we've been focused on how we translate these recommendations into tangible impact, which actually improves patients' lives. We've partnered with dataset creators, developers, regulators, funders, journal editors, and other key gatekeepers and stakeholder groups to ensure that these recommendations are adopted widely across the healthcare AI ecosystem. In doing so, we hope that we can improve documentation and use of healthcare datasets to enable medical AI systems which are safe, effective, and promote health equity. These recommendations reflect collective wisdom of hundreds of our contributors, without whose help this work could never have happened. The project's being co-delivered by our team based in Birmingham in collaboration with our working and consensus groups and our public partners. Thanks also to the Health Foundation, the NHS AI Lab, and the NIHR who have funded and supported this work. There's a link to our website on this page. It's www.datadiversity.org, or there's a QR code you can scan if that's easier. On our website, you can find the current draft recommendations, and these will be updated to the final set of recommendations later this year. So thanks all very much for your attention, and I'm really happy to take any questions, or feel free to reach out to us via social media or via email.